Um, sorry, hold on. Rob, oh, two participants. Okay, good. Um, I just want to mention really quick that we do have the exam next week, no lecture afterwards, 50 multiple choice, and the questions, there's 10, roughly speaking, this is the way it's divided, 10 on diabetes, 10 on respiratory, 10 on the each, so 20 total from the very first week where I did the IDD and DD, intellectual disability and developmental disability, and intro to special needs. So those two PowerPoints, they get 10 questions each. And then substance misuse and eating disorders, 5 each. Does that add up to 50? Yeah, that's 50. So that's how so it's less on substance misuse and eating disorders, but there is some questions there. So a lot of stuff you'll notice in these PowerPoints, if things are bolded, starred, or highlighted, that's, pay a little closer attention to those, but certainly, study the whole PowerPoint. And also, because remember, it's not just like passing my exams. Special needs is tested heavily on the national board. And this is all supposed to get you guys to holistically think of your patient care. So you guys have compartmentalized everything, like now I'm probing, now I'm exploring, now I'm going to remove calculus. But you really have to start to put the whole thing together and think in terms of changing up things slightly as you get different patients with different needs. And so you need to, and that's going to feel uncomfortable and weird. And you want to just be told, I'm going to do this, but that's part of the evolution. That's part of how you'll evolve as a healthcare provider. You'll start to be able to think on your feet and put things together. And when you go out on rotation, they're going to really want to see that skill gets honed, and you guys will be able to work faster and see varied patients. So it's almost easier when you go out on rotation because you have that opportunity to move through the appointment faster. Okay, enough of that. So we're going to talk about diabetes. So what do you guys think of when you think of a patient with diabetes that is in your chair? What are some of the things that you think about that you'd want to just be aware of, that you might want to ask them about?
What's your A1C? Your type of diabetes?
Medications. Did they eat? When did they eat? A1C, all those are good stuff. Good stuff. Are they in general, generally well controlled? Or, has everything kind of been the same for a really long time, or is something new? So, a lot of this stuff is review. We've talked about it in pharmacology, very in depth. So there's a lot of this stuff that I'm not going to linger on. I'm going to try to make myself not talk too much, because a lot of this stuff is review. And then the stuff that is more like what you're going to think of as application is more in the second half of the PowerPoint down here, these last objectives. So we're thinking of just questions you want to ask, things that you want to be aware of, how to prevent a medical emergency, what would make somebody maybe have a medical emergency, what kind of situation could happen that if they came into your chair and they told you XYZ, might the bells go off in your head and go, that kind of puts them at a higher risk for a medical emergency. So I kind of want to be on high alert. I want to ask them a few more questions, things like that. Okay, so your role as a dental hygienist. So the ASA for some person who has diabetes, well-controlled type 2, which is by and large probably what you guys are going to see in senior clinic, would be ASA 2. But if there's type 2 uncontrolled, like their blood glucose is just wildly swings and they're high and they can't get it down, and blah, 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 then they're going to be an ASA 3. And a type 1 is always an ASA 3, because if they don't have their meds, they're not going to survive very long. So it's a much more serious form of diabetes than type 2. Type 2, usually people can get away with a little bit more, especially in the earlier stages of having it. Sorry, I skipped that too fast. So we do our risk assessment. We think about co-management, what kinds of other healthcare providers are active in this person's life. Maybe you want to recommend some healthcare providers. Maybe they don't see anybody and they've admitted some things. Maybe you can say, they have diabetic educators that hospitals sometimes put on classes that can help you talk about lifestyle and how to control diabetes better and the blood glucose. So you could talk to them about different things. This monitor the pharmacological history of drug interactions with glucose control. That makes you sound like that sounds scary to me. Like that sounds like a lot of responsibility. I don't think I want to do that. But really what it just means is if you have somebody that you have had in your chair for a long time, you know the medications, you know their general ability to control their blood glucose, are things going well? Or do you want to say, you've been on this med, you don't take it very regularly. Maybe you need to go back and counsel with your doctor, or you've been on this med, things aren't staying low. Maybe you need to revisit a different kind of medication. You're not prescribing, you're not specifically recommending, you're just like giving them a heads up from somebody who is a healthcare provider. So you're just kind of monitoring things for them, giving them another educated brain to help them keep their condition stable. Minimize potential risk for emergencies. We'll talk more about that. Detect undiagnosed and uncontrolled diabetes. If you see signs, say something. Like it could be nothing, but it could be something. So it's just saying, be aware, speak up if you notice something in your patient. Modify dental hygiene care plan based on their needs. We'll do that with just everybody. And then you evaluate the outcomes. So as a reminder, diabetes is basically, it's a person that either is not making insulin, they aren't making enough insulin, or their body is just not using insulin well. So it's one of those things. And we remember that insulin is a hormone. It's an anabolic hormone that the body produces in the pancreas. And if you're type 1, you don't make it. All of those cells have sort of been killed, or they've died off, or they've self-destroyed in one way or the other. And if you're type 2, you probably make it, but maybe you just don't use it well enough, or maybe you don't make enough. So different things can go on. And then that's just a normal blood glucose. Between 70 and 120 is considered relatively normal. Some people might come a little bit out of that range, but in general, that would be normal. So this is sort of a synopsis. There's a lot of good notes in all of these slides. I encourage you to read the notes just to expound on the information, just to give a better sort of understanding of what the slides are trying to encapsulate. So I would read through the notes when you're doing your studying too. But so type 1 and type 2, there's a lot of overlap in symptoms, especially when somebody is uncontrolled or when the condition first comes on the scene. So if somebody like a young person all of a sudden develops type 1, or if an older person has had type 2 or prediabetes for a while, but then their body starts kind of just saying, okay, I've had enough, and they start showing more signs, there's a lot of overlap. But the main differences between the two, type 1, there's no insulin produced. Sometimes when the person is just getting diagnosed, they might still produce a very tiny amount, but essentially there's no insulin produced. It's usually a genetic, but it can be an environmental factor or a virus or a medication trigger, but usually it's something genetic. And then it's going to be their whole life. They haven't figured out how to get the body to start producing insulin again, but maybe one day technology will do that. Who knows? And then it is a lifelong autoimmune condition. So if you get a question about which type of diabetes is an autoimmune condition, it's type 1. Or an autoimmune disease. Type 2, it's far more common, like 90% of people with diabetes have type 2. And largely it's really lifestyle related and preventable, although there can be a predisposition, like a genetic or family predisposition to it. But generally speaking, we've seen the dramatic increase of type 2 diabetes through the years with, we have a lot more processed foods, we have more sedentary lifestyles, high sugar diets, things like that. The body, yeah.
Is that like globally, or is that?
There are definitely regions where you can study the culture's diet, and they have like almost no diabetes, but the like McDonald's can put a McDonald's like on any corner practically in any country. So I feel like, like Japan might have like had like very low diabetes, but I think now, things are kind of changing. But yes, you used to be able to see like almost like by like a diet that was like something that people had eaten for hundreds of thousands of years. Well, not hundreds of thousands, but hundreds or thousands of years. And they were just very low risk for heart disease, diabetes. So I do think it's the American diet is, and there's a lot of literature that supports that. It's always going to be maybe people that have a different view, but you used to be able to see it more specifically country by country. So that's a good question. Lifestyle, genetics, 90% of diabetes treatment, lifestyle changes, medications, and then possible to go into remission. There are doctors that really talk about their diabetes plan and how they can reverse diabetes. Some doctors don't like that. They're like, can't do it. There's always medical debate on people's theories, but there is a lot of literature that supports that it can be controlled anyways or put into remission. Okay, gestational diabetes, 2 to 10% of pregnancies in the US. Higher risk individuals, usually somebody maybe who's had other kids and they had gestational diabetes prior. If there's obesity or family history, this risk seems odd because it almost seems like a result of having it, but this is what the textbook said. If they have glucosuria or glucose in their urine, but to me, it's a strange way of saying that's a risk because that almost seems like a symptom of it, but that was how the book put it. So I just stuck it in there. But that is what they're testing when women are pregnant and they're testing for protein, they're testing for sugars, and they're constantly, every time you go to the doctor when you're pregnant, you have to pee in a cup. And so they're just testing your levels of those things. Generally, it will revert after the mother gives birth. All those hormones that are in the body, they tend to make the mother more insulin resistant. And so that is one of the factors that kind of makes it happen. So once those hormones sort of go back down to normal baseline level, then things usually revert, but it does put them at higher risk overall for developing type 2 diabetes later in life. And then there is kind of like almost like a type 3. Some medical literature is calling Alzheimer's type 3 diabetes because they're seeing some similarities. But there's other types of diabetes too that can just not fit nicely into the type 1 or type 2. One of my friends, she got what they diagnosed as type 1 diabetes, but she's older and it came on very suddenly and it just didn't fit the normal. She's very active. She's a nurse on her feet like all the time. And it just didn't like fit the normal, mold. And so hers probably would fall into one of these other types of diabetes. This chart just kind of summarizes like normal levels pre and diabetes for HbA1c, or if someone goes in for a fasting blood glucose test, or if they go in for just a glucose tolerance test. Those are some numbers. I might have told you guys when I was pregnant with Lola, I had to do the fasting blood glucose I did the glucose tolerance. And I think my numbers were a little bit high. And so they wanted me to do the fasting. And that was so uncomfortable because you don't eat anything. And then they load you up with these sugary drinks. And it is so uncomfortable. But I guess I ended up passing the second one. I don't know. I probably was borderline. I eat too much sugar. So did it happen to you too? Oh my gosh, they were awful. I went up to the lady. I do not feel good. Like you're
I was like, I'm gonna be sick.
Yeah, that's what I was
They're
like.
not good.
I do not feel well.
Yeah.
And she's like, oh, that's normal. I'm like, thanks. Okay. So some common cardinal symptoms of somebody who probably is either uncontrolled or maybe they're just developing it, is just coming to fruition, and the first one's fruity, is a fruity acetone breath. So it almost smells like alcoholic. It's like fruity, like rotting fruit or something. That's why they call it acetone. It's like fruit and alcohol. I don't know, it's weird. But I've smelled it a couple times, but the one guy that I really remember, I was like, is that what it is? Or did he drink something? Like and I even mentioned it to the doctor. And sometimes, when you're young, fresh out of school, and you notice something that you remember from school and you mention it to the doctor because you're like, no, it just kind of smells fruity. Sometimes the doctor, if they don't take you seriously or say something, you don't feel like you can say anything, and that's a very normal feeling. Sometimes we learn this stuff and then it's hard to implement it because you don't want to tell the patient you might have diabetes, but you can mention it. You could say, I do notice something that smells a little bit fruity, and that potentially, if you have any diabetes in your family, it's not a bad idea to just get your blood glucose checked. It's really easy. The nice thing about modern day, like when I was working fresh out of school, we would never in a million years have done this. But you can advocate for your office to do blood glucose screening, and you could just do it right then for your patient. Like if you had a question, you could do a blood glucose test, and just like you guys do in clinic. So that's like kind of a more accepted thing that I think more offices are doing. All of these polys, they love these kind of questions on the national board. So make sure you know these medical terminology. Frequent urination is polyuria. So those synonym, or what's the second half of the word? Is it not synonym? What's it called? Yes, suffix. I was like, what is it? What's the S word? Yeah, suffix. So you read like dyspsia, thirst, phagia, hunger. It's also like swallowing. Dysphagia, it's like difficulty swallowing. So I don't know. I think the phagia actually has more to do with like a function. But anyways, kind of try to memorize those. And then poly is excessive or more, or up, increased, or what, however you want to think about it. But frequent urination, excessive thirst, unusual hunger, weight loss, and poor wound healing and current infections. That is the star, everything that has to do with dental hygiene, periodontal disease. These patients are immune compromised, and that is the take home. If you forget everything else that you learn about diabetes, you remember that these patients are immune compromised, especially when they are not well controlled. And if they're immune compromised, a chronic infection in their mouth is going to be harder to take care of. And that's just that. I could just say that and we could say class over. And because that's like the main thing that this PowerPoint tries to iterate in like a million slides. Some chronic health problems that people with diabetes will have, but more so the older they get and if they haven't been well controlled. But even if they have been well controlled, just it's harder on the body to have, these things happen. So generally speaking, this would be people that their blood glucose swings wildly more throughout, many years, but microvascular and macrovascular diseases. So that's going to be anywhere from atherosclerosis to the tiny little blood vessels in the eyes or that go to the kidney and things like that. So it weakens them. It's harder for, they just become unhealthy. There can be buildup, and that's another association with the brain and Alzheimer's. That's why they call it type 3, is because they're noticing some vascular disease that is affecting the brain as well. Diabetic retinopathy with potential vision loss. So older individuals who have had diabetes a long time, maybe not so well controlled, they can lose vision. These two N words can get mixed up, but nephropathy, nephro meaning the kidneys, so renal failure, and then peripheral neuropathy, that's nerve damage. So very common for individuals with diabetes to have numbness in their legs and feet. They also have poor circulation because of the vascular disease. So poor circulation, numbness in their feet, they get an injury, they don't notice it, it festers, it gets infected, they can lose toes. So if it keeps going, they lose feet and parts of their leg if it just keeps going and going. And this is usually very ill people who are not controlling their diabetes or haven't been able to for whatever reason. Autonomic neuropathy, gastrointestinal, genitourinary, cardiovascular, and sexual dysfunction, pretty much anything that needs blood and nerves, which is our whole body. So you can pretty much have it be affected anywhere. And then periodontal disease. So again, that being able to heal, to respond to, wounds or infections, and then the whole inflammatory process is just much harder to control when somebody has diabetes. This slide, I'm not going to go over each one, but just kind of read. I don't believe there's any specific test questions off of this, but it's just a really nice, informative slide. So just for your knowledge, make sure you read through this slide. But these are the main areas where you can see eyes, kidneys, neuropathy, extremities, cardiovascular disease, the heart, and then the brain. They all are part of the complication of chronic diabetes. And usually somebody that has diabetes as they get older certainly will have more than one condition. They have comorbidities, they call it. You have multiple things that are going on and taking medication. Very oftentimes they're taking heart medication, they're taking diabetic medication, and other things. So just kind of to summarize, typically it's more common to see kidney diseases and eye diseases with type 1, but you certainly can have all of this with anybody, but these are just kind of a little bit more common. Atherosclerosis or heart cardiovascular conditions are a little bit more common with type 2. Neuropathy, the nerve damage, is very common with both of them. And then like it says, you can have both. So periodontal disease. So these are all really important bullet points to think of. So the prevalence and severity of periodontal disease increases just for if somebody has diabetes. It's just they are going to have a harder time controlling their periodontal disease, and they're more likely to develop periodontal disease if they have diabetes. Now, that's not like too bad, you're just destined to have diabetes or you're destined to have periodontal disease. But if they're not careful, that's the road that they'll more easily go down. Bolded here, A1C greater than 8%. Those individuals have a greater increase of periodontal complications. So if you have somebody in your chair that's a 7, their body they're just consistently at a 7, their body is just more stable. They're just going to be able to kind of handle the onslaught of an infection. They probably will heal a little bit better. Maybe their periodontal disease will stay a little bit more stable. 7 is still above normal. Like, what is it? 5.6 or something is normal. So they're still out of the normal range. They still have to be very diligent, but they're gonna be able to stay a little bit more stable. I had a patient at Dr. Matsuda's, his A1C was like, I don't know. It was, I want to say it was like 13. I mean, and he had, I swear I was scaling like on his apex of 14. I'd be like, I'm up here. It curves. Something, either the tooth broke up there or I'm at the apex. I mean, he just had, and he was such a sweet guy, but he was hard to, it was a very challenging case of perio and diabetes. Glycemic control is an integral part of controlling periodontal disease in a diabetic patient. So a spiel that you want to memorize, and you want to be able to know this stuff, like to say it easily and quickly to your patient, is when you have diabetes, and it's not controlled, if it's like, fluctuates quite a bit, it is harder. Your glucose is swinging. It is harder for your body to handle an infection anywhere. It could be an infection in your foot or an infection in your mouth. So when you have diabetes and you're not well controlled, infections are just harder for your body to deal with. And thus, when you have an infection, it is harder for your body to stabilize its glucose levels. So they call it a bi-directional relationship, a two-way. They affect each other. They like totally affect each other. If one is out of control or it's it's gonna make the other one harder to control or become out of control. And so the lesson, or what you're really trying to educate your patient on, is let's get your mouth healthy. Like, let's do everything on a daily basis to get your mouth healthy. Because if your mouth is healthy and you've stabilized your periodontal disease, it is going to help you control your blood glucose levels, because those just are going to swing more, be harder to control. So that's just like a story you want to tell yourself so that you can tell your patients that, because you're going to have a lot of patients with diabetes, just in general in your lifetime. So hyperglycemia leads to an increase in those, you've all probably heard the term pro-inflammatory cytokines. Whenever you have an infection, or whenever there's an infection, all these inflammatory things in your blood, we're going to fight a disease, let's go, they all flood it. But if you get too much, that's when it's a balance, and they kind of get overzealous and they start actually causing some destruction. So that's where we get the destruction of the bone and the connective tissue and all the supporting structure. So you can see how diabetes, hyperglycemia, and periodontal disease are just like, ooh, they're just very intertwined, and they make each other worse. Okay, so periodontal disease and the diabetic patient. So a little bit more information. So positive outcomes are not always typical. So what that means is you could do an SRP on a diabetic patient and it could be like perfect. Like you could do a really good SRP, smooth out those root surfaces, and they could still not respond as well as somebody else who doesn't have the condition or the disease. And that's kind of a bummer, but it is something that you have to take into consideration. And they might have to work harder to try to control the biofilm and keep things really clean than somebody else. Removal of hard and soft deposits are crucial, so you still want to do it. It's hard. It's not on this slide. It's, I think, on another one. But we have a cutoff. Like if somebody's blood glucose is above 240, or if their A1C is a certain number and their blood glucose is above 200, we can't see them. And that feels very conflicting, because it's like, so what? We're just going to leave this patient with diabetes in a state of infection? Like, that doesn't seem right. So we've had this conversation a lot, and I will just let you in on a little secret. Out in the world, most offices don't check blood glucose, and they would have no idea if the person came in at 350, if they came in at 180, and they just do the procedures. So that could be changing through, and the only time I think people really pay special attention is when they're going to do a surgery. If a doctor's going to do a surgery, they very likely might check blood glucose, make sure the A1C's on record. But many general practices, when just the laity come into your office and you're just cleaning people's teeth, it's not, we take blood pressure. We always know our patient's blood pressure, but you likely will never know your patient's blood glucose in a general practice. But hopefully I can eat my words and you'll come back and tell me, no, we take blood glucose. I never, because that could be, it's just, I have not seen it to be something that's very commonly done. Okay, where was I? So SRPs indicated evidence supports antimicrobial treatment. So there are great literature out there about doxycycline, low dose doxycycline. It's so low, it's not even considered really like an antibiotic. It's considered more of like, it helps promote the collagen, like protects the collagen. I can't remember exactly what it does, but it's not technically like used as an antibiotic. So there's evidence sometimes perio offices or even general practices might be in the habit of doing an SRP and then having the patients do this doxycycline twice a day, low dose. Patients with diabetes don't always have to have a pre-med. If they have very, very, very uncontrolled, like way out of the range, a doctor might say, I just want to put you on an antibiotic, then we'll do this procedure. So it's usually more case by case. There's literature that says that the theory is that epinephrine, if it floods the body can affect blood glucose. And we're worried about our patients with diabetes, their blood glucose level. So if you use lidocaine, if you have to use several carbs, their blood glucose is already sort of on the edge. There's a caution around that. However, I read several journal articles, and many of them did studies, and they found no change in people's um, blood glucose levels before and after they used local anesthetic. So I feel like that's sort of out for debate, but in general, that is something to be aware of. Is in theory, epinephrine can affect blood glucose levels, and so that's twofold. We think about it when we give local anesthetic, but we also think about the stress level of our patients, because how else do you make epinephrine? You get it in your local anesthetic, but how else does it come about in your body? You just make it, right? It's endogenous, exactly, stress. So if your patient is super stressed out, that could also theoretically, like maybe potentially really affect their blood glucose. I'm not testing you. Oh, maybe there is one question on diabetes medication. There's not gobs of questions on medications, but I can occasionally throw them in. Diabetes meds are very common. You guys should just keep those names in your head. I swear they're going to ask. You'll hear this on the national board, so don't just compartmentalize it and forget it. Keep this stuff in your, go through the rounds every once in a while. Be like, what do I know about this? What do I know about that? And just keep it kind of in there, so it doesn't totally drop out. But there's so many medications for diabetes. These are just some very popular ones, very popular classes with the biguanides, sulfonylureas. The one that everyone talks about is the GLP-1 receptor agonist, like Ozempic or Wegovy. But obviously people will be taking drugs that you've never heard of. So Lexicon is our friend. Okay, so some process of care information. Just like what you guys so brilliantly said at the beginning of class when I asked you, I feel like a lot of you already have this sort of keyed up, and that's awesome. Do you know their blood glucose levels? What's their HbA1c? Have that on record. An infection can profoundly disturb glycemic control. So you want to have that in your knowledge bank so you can share that information with your patient. An infection is the most precipitating factor in severe ketoacidosis. So when somebody, their blood glucose just goes like through the roof and they have a diabetic coma, basically, the biggest reason why that occurs is because they had an infection somewhere. And who knows, it could be like really bad periodontal disease. Like it could be a really bad perio infection that precipitates that. Poor diabetic control may aggravate oral disease status, just like what I said before. It's that bi-directional relationship. Stress, because of the endogenous epinephrine, that can contribute to hyperglycemia. And it's vital for diabetics to understand their susceptibility to periodontal disease. So writing yourself out a little script that you could easily talk to your patient about will really help you get comfortable with saying those key things about blood glucose and oral infection and how they're not friends. They make each other worse. Okay, so some more process of care for the health history. Of course, we want to assess any risk of them having prediabetes, or if they're stable, their risk for diabetes. The CDC recommends that people know their patient's A1C and maybe even do those blood glucose tests, just like what you guys do in clinic. The aging population, they don't show up with the traditional symptoms. If they've had a slow rise of glycemic rise for years, they could have high blood glucose and feel fine. They're like, think anything's wrong with me? Because your body, it's almost like atherosclerosis when your vessels slowly close. Like your body adapts. It's when a chunk breaks off and blocks your arteries suddenly that you end up having a stroke or a heart attack. But when the lumen of your vessels just sort of narrows, your body's just kind of like, I can get used to this. And it's the same thing. Now, that does not mean it's healthy, and that doesn't mean it's like a good thing, but you won't necessarily feel the major negative effects. So older people also, they can have funny things, aches and pains, and I have to pee a lot because I'm getting older. Like there's just all these things that can happen with older people. So sometimes the traditional symptoms are not always there. And then you often see a lot of comorbidities with the aging. Okay, this just has a whole bunch of things like that you want to think about when you're going over the health history. You guys will get very used to the health history in our clinic. When you go to your job, your first job, you'll get used to that medical history form. But try just to remember not to be robotic. It's easier said than done. Things can get very like kind of routine, and you just ask the questions and da 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 da. And especially once you know your patients really well, it's hard not to get a little bit robotic, honestly, but you want to try and remember that their condition is a real disease, and they could wake up one day and something could have changed. So you really want to ask them those questions. The date of the last hypoglycemic episode is really important. If they at all have a risk of becoming hypoglycemic, you want to know that. So all those things like, how's your meds going? Are you taking them regularly? How's your blood glucose? When's the last time you saw your doctor regarding your diabetes? All of these things. What do you normally eat? Did you eat your normal food this morning? And they'll come in and say, oh no, I didn't. I was running late and I didn't eat anything. And you're like, oh, shoot. Well, did you take your meds? Yes. Oh, double shoot. Because if they take their meds and they didn't eat, that's like not a good thing. And so you just want to kind of really get used to talking to your patients about that stuff. This is our protocol in our clinic. There is a question that asks based off of this specifically, and I mix it up. So I get a little tricky, not because I like being mean, but just because I want you to really know these levels. Well-controlled 7, they can go up to 240. An elderly below 8 or less can go up to 240, right? But anybody that's above 7 or an elderly above 8, 200 is the cutoff. And then we can't see anybody in the clinic who has an A1C over 11.1, I guess. And so just be very comfortable with those. Make sure you know those. Okay, oral assessment. So some things that are going to be more common in a patient with diabetes, their oral health, of course, they could be at high risk for periodontal disease. We've talked a lot about that. But they tend to have more glucose in their saliva. So that does put them at a higher risk for decay, obviously. They're immunocompromised. So that puts them at higher risk for opportunistic infections like Candida. And then they're going to heal slower. So they could have ulcers or a wound that's not going to heal as fast. The angular cheilitis is another yeast infection. Dry mouth xerostomia is also quite common. And of course, that's going to make it harder for them to control caries. Glossidynia or burning mouth syndrome is something that can show up in patients with diabetes. And that's a really hard one to explain. It might have something to do with neuropathy. Yeah.
I was talking with a patient about that has diabetes, kind of about like they do get really bad dry mouth. And so I was kind of because she's like, I really like to have like something I'm chewing on. I love snacks throughout the day, odd things. So like I kind of brought up xylitol and like xylitol products. So those are good products for stimulating, and it's okay for, I guess part of me is like, well, it's a sweetener, but they're diabetic, so it should be okay because it's good for, bacteria in the mouth.
Yeah, no, I think that's some people have to watch how much of it they eat only because it can cause like some GI issues in some people.
Okay.
So that's just something to be aware of. And if they have a dog, tell them like, don't let your dog get into any of your xylitol stuff because it's really poisonous for dogs. But xylitol is a really good one because it like starves the bacteria in the mouth. But I think any sugar-free, obviously sipping on water, ice thing, ice chips, but anything sugar-free, but I think xylitol is a really good one. And there's some new products too coming out, like there's one that's actually made from like, this sounds gross, but it's made from corn oil. And so, but it's a saliva substitute, and it's just like a spray, and it keeps it's been at the conferences lately. They've been talking a lot about it. And this one speaker was talking about oral cancer, and she kind of promoted the company, and I can't remember the name of it, but said it kind of does leave like almost an oily texture in the mouth, but it's very moisturizing and it stays much longer. So there are a lot of products you can investigate, and you guys will have more opportunity to do that as you go to CE classes and go to conferences. But yeah, xylitol is a great recommendation. So dental caries is obviously they're higher risk for dental caries. The other thing too is dentures and things like that could be more uncomfortable for them to have in their mouth. They just might not, if they have dry mouth, if they have a sore, the denture might rub. It just they could have the yeast can build up and be irritating. So you also have to be really good about educating them when they have a partial or a denture. Okay, so for diagnosing and planning, it's really very the same. You're going to plan your SRPs. You're probably going to encourage more frequent perio maintenance. You're going to talk to them about maybe like the delayed wound healing and how to stay on top of the biofilm reduction. You really want them to make sure that they're, maybe using a water pick or using, just all the different things that you think would work with that patient. If it's proxy brushes, if it's floss, if it's an electric toothbrush, if it's a mouthwash that you think they would, but a lot of patients want the mouthwash to take the place of proxy brushes or flossing, and it just doesn't. So you have to learn to kind of work with them on that. But when it comes to the things that you want to make sure that you're thinking about in terms of their specific blood glucose levels, most diabetic patients will prefer a morning appointment. That's not to say everybody in here in our clinic. I've had situations where patients came in and their blood glucose was high at like 10 o'clock, but their blood glucose stabilized in mid-afternoon. So the textbook and everybody usually says morning appointments, people do better. They're less stressed in the morning. They have more energy. They've taken their meds, all these things. And that could be very true, but there are always exceptions. So don't feel like it's just, a test question might encourage you to answer at early morning appointments, but that doesn't mean that everybody's gonna be that way. You do have to think about when they ate, when they took their meds. Usually blood glucose has stabilized about 2 hours after they've eaten and taken their meds. So if they've done it right out the door and then come to see you, things could be more unstable. SRP and periodontal debridement are contraindicated if the person is uncontrolled, but that's controversial because what are you going to do? Just leave this infection in their mouth? So there's a lot of debate on it. But I think it's a liability thing. Like people are afraid. I saw this post on, I think it was Facebook, where in one of those dental groups where she'd done a half mouth SRP and the person ended up in the hospital with sepsis. And the physician said, well, it could have been from the SRP. And she was so freaked out. She didn't want to do it. And she didn't want to do SRPs anymore. And she's like, what do I do? I'm like, oh my gosh, I've cleaned some very unhealthy mouths where there's a major bacteremia. I mean, a bacteremia happens even when it's not that bad. I mean, we give ourselves a bacteremia when we floss sometimes, bacteria in the blood. But I've never caused anyone to have go septic before or have sepsis. So weird things can happen. And that's where that controversial piece comes. They're like, diabetics are harder to control in they're immune compromised, blah, blah, blah. So, just go to lots of classes and learn all you can and be on the same page with your doctor. And that's usually the best place. And always consult and refer to a physician. That's your best, if you've done that, you've covered all your bases. Inform the patient with diabetes and periodontal disease that their glycemic control may be more difficult and that they are at higher risk for other complications such as cardiovascular and kidney disease. That's your take home message. You want to talk to patients about, yes.
Sorry, you finish. I just
No.
had a question about the previous slides. Is that just up to your office, whether or not you can do it with uncontrolled?
It seriously is up to your office. Like,
What
does
is
your
here?
Here, no, we have a hard cutoff.
Yeah, but the hard
Uh-huh.
part-
And we've talked about it.
that puts them in a different ASA, but
Yeah.
out in practice, it just depends where you go.
Yes. And the doctor I worked for,
Yeah.
he would have a patient with uncontrolled diabetes come in and want an implant. And he would say, you are harder to do an implant on. It won't heal as, the healing is unpredictable. The life of the implant is unpredictable. And if you're good with that, or he would do the same thing with smokers. Like if people were heavy smokers, he's like, you are immune compromised. Your vascularity is not as good as someone else's, all these things. And I need good blood flow for healing and blah, blah, blah. And they tell them everything. And if the patients are good with it and it's informed consent and the doctor's okay with taking on that, then, that's usually how it goes, right? So, but yeah, it is definitely, schools are always like, this is our hard line, and then the world does different things. And it depends like office to office, I would say
So
for
like
sure.
in the case of like that girl that you were saying, like what if, like, does she get to say that she doesn't want to do them anymore? Or is that like?
I think yes, I think that's she had in her post, she was saying how she had major anxiety about doing the second half of the SRP. I probably would too. I'd be like, I would probably at least put them on a pre-med, like say, be on antibiotics and then I'll do it. That's probably what I would do because that seems very like random to me, but definitely unnerving for sure. So this slide, talk to your patient about the risk, teach them about their subgingival cleaning, saliva replacements if they have xerostomia, discuss their maintenance if they, the long-term maintenance of your teeth and keeping your natural teeth so that you can continue to eat healthy foods like carrots and apples so that you can try to keep your diabetes controlled. Diet and lifestyle, you need your teeth, you eat healthier foods, crunchier foods, all of it plays a part together. So if you can paint that picture for your patient about the importance of a healthy diet, keeping your dentition, minimizing infection, all of this stuff, you kind of it all rolls up into one important narrative that you want to, really encourage your patient. And you're not going to have a bunch of time to just sit there and wax eloquent on that, but you can, every time you see them, you can insert little things and reminders to help them. And we kind of talked about the dentures. Let's see. So after I'm trying to get through this slide deck and then I'm going to give you guys a break. Okay, so emphasis on oral biofilm, monitoring their health status. It includes nutritional and dietary counseling, fluorides, chlorhexidine, xylitol. There's other ones. There's so many good ones now. I should update it with other things because there's so many products out there, more natural products. If people tend to go that way, you can say, I've heard there's research around this, or you can stay in the know about all of these new things coming out. And some things are, SDF is not new. It's new that we use it, but they used it like 100 years ago. So some things come back in style. Salivary replacement, frequency of maintenance. Usually an individual with diabetes, you'll usually see them more like 3 to 4 times a year as opposed to twice a year. But that's, if they're super well controlled and they're healthy and their mouth is healthy, you don't have to see them that often. You can manipulate that time schedule. And then collaboration with other healthcare professionals. So well-controlled diabetes, people can respond really well to SRP. So the slide before that was like, they might not respond well. That's talking about your general population that might not be as well controlled. If somebody's really well controlled, their periodontal disease is mild, maybe they just have 4s and 5s, and they kick up their OHI, they probably will do great. So it's not like this tragic tale of you're going to lose all your teeth because you have diabetes, but they definitely are at a higher risk. And so you want to be able to educate people on that. Delayed healing may indicate hyperglycemia. So if they're not, if they think they're really well controlled and you're seeing all these signs, you might say to them, I don't know, these pockets are not responding. I've been doing a lot of work in that area. There's not a lot of biofilm. I'm not getting a lot of plaque in that pocket, but it's not responding. I really think you should go back and have your doctor check your levels and maybe do an updated A1C. And then just record everything, everything that you do, record the things you talk about so you can kind of track what the patient's been doing and the progress that they're making. Okay, so the last bit here is just about medical emergency. So what's more common for a medical emergency, hyperglycemia or hypo? Really? Okay, that's all. I don't have to say it. So just remember that everyone thinks hyperglycemia. Now, diabetes is characterized by hyperglycemia because what is happening when someone doesn't know they have diabetes? Like if you haven't started taking medication and you're like, I have all these symptoms. Well, that hyperglycemia is one of the main characteristics of diabetes, right? But once somebody is taking insulin, or once they're taking, metformin or glucoside or any of these glycate, well, I don't know, whatever yes, that one. Whenever they're taking that, those medications give you insulin. They kick up insulin production. And if you have all this insulin and you're not eating, then you're at risk for hypoglycemia. So that is really the most common medical emergency is hypo. So just pin that in your brain because that is a test question. And so this kind of goes over some of the different things. Think of hypo as fast onset, your blood sugar drops and you're just like out. Slow onset, diabetic coma is a much slower medical emergency. People usually have time to someone kind of figures out something's not right and someone's getting them to the hospital, where hypo can come on very quickly. You can get very sick very fast. So this sort of summarizes it. Hypo, you can have altered consciousness, fast onset, could happen in minutes. Hyperglycemia, altered consciousness again, especially at the end stages with diabetic coma, slow onset and gradual. It could even take days of somebody just building up or being in a hyperglycemic state for days. So for hypoglycemia, that's the blood glucose below 70. And some people get that way. Like I certainly have especially in my younger years, I used to drop below 70 a lot and get shaky and nauseous and kind of cold, sweaty, clammy. Especially if I was working hard and I didn't eat or have a snack, I'd drop down before lunch. So sometimes that happens to you and you kind of know that about yourself, but it's different if the person has diabetes. You want to take it really seriously if the person has diabetes. So most common metabolic emergency of individuals with type 1, and they take their meds, but they don't eat. So some of the things that you do, we give them 10 to 20 grams of glucose. That can be 8 ounces of milk, 4 ounces of orange juice, couple hard candies. We have the little glucose tabs in the medical emergency kit. More severe cases, they go unconscious. They may require, if they go unconscious, they might require an IV solution of dextrose or an injection of glucagon. 1% death rate, much lower than years before so now this is hyperglycemia or ketoacidotic coma or diabetic coma. So again, like I said earlier, if they've had an infection in their body somewhere, a large infection, that can be that predisposition or that kind of kicks them into this out of control blood glucose going up and causing this diabetic coma, high blood glucose. So it requires hospitalization. They're gonna take them and do whatever the doctors do. And it's a combination of low insulin. It's acutely kind of characterized by low insulin and high blood glucose. And that's when you have that for a long enough span of time, it can put you into a ketoacidotic coma. That's it. Oh, okay, that was it. Anybody, okay, so it's 10 o'clock. Let's do, oh gosh, I don't know if I can do the other one in 50 minutes. But we'll try. Let's do like 7-minute break, maybe just to get up if you need a coffee, maybe you have enough time to grab it and use the restroom, and then we'll come back and we'll do the respiratory. Okay, so the respiratory, this is gonna be a marathon of information. Um, you guys are I feel like we cover asthma. I feel like we cover asthma really pretty thoroughly, so I'm gonna like breeze through asthma. Um, this is just all these objectives are talking about. We're just discussing kind of the role, some things that you want to look for when your patient is in your chair. If they're in your chair with one of these conditions, or if you notice they have, a sign or symptom, and you can kind of talk to them about some things, and also like triggers, contraindications, things like that. So we're going to basically touch on asthma, COPD, emphysema and bronchitis are together COPD, so that's kind of redundant. Tuberculosis, pneumonia, and OSA, which is obstructive sleep apnea. And I really want to kind of fly through the first several because I feel like this is almost like the same PowerPoint from pharmacology. I mean, it's like pretty close. So I just kind of want to fly through it and get down to pneumonia and OSA because those I feel like we didn't talk about as much in pharm. So just make sure you read study the PowerPoint, make your notes, review it, make sure you're comfortable. I highlight the definition. Asthma is a chronic inflammatory respiratory disease. So it's chronic. When someone has asthma, unless it's like they grow out of it, usually people have asthma like forever. Maybe it's exercise induced or stress induced, or maybe it doesn't seem as severe as when they were a kid. But if someone has like full blown asthma, it's not like it goes away typically. So there are, sort of exceptions, but generally speaking, it's chronic inflammatory, increases the response of the bronchial airway to various stimuli. And you can see all the various stimuli, and it's categorized as either intermittent or persistent. So that's a severity, either, it kind of comes and goes or it's like all the time, and then mild, moderate, and severe. If somebody is well-controlled asthmatic, they're still an ASA2. And so obviously if they have a more severe case, they're going to be like a 3 or potentially, I guess, even a 4, and you wouldn't see them if they're that hard to control. You guys can only see patients at a 3 and below, I believe. You want to talk to your patient about their triggers. You want to know, you want to talk to them about their triggers, and you also want to make sure they have their inhaler. Now, if they're like, yeah, I have asthma, but I haven't had like an asthma attack since I was in high school, and it was because I was running, and they're like 30, but they're still marking asthma on their medical emergency. If they don't have an inhaler, you're probably not going to freak out. But if they have like wheezing attacks, or something gets them triggered, you do want to make sure they have their inhaler with them. They really should have their inhaler. Wheezing, dyspnea is difficulty breathing, tight chest, feeling of suffocation. It can increase their pulse and blood pressure, of course, too. You want to talk to them about just the frequency, just like with diabetes. How often do you have this? What triggers it? Do you have your medications? Do you take an oral medication or a steroid? Do you take an oral steroid, or do you just rely on like an emergency inhaler? You just want to understand the severity. Have you ever had to go to the hospital? Has there ever been a medical emergency? So these are just common sense. You're curious, just be nosy. You want to know all the things about your patient. Hygienists are good talkers. Usually they're nosy people. No, I'm just kidding. You guys are nosy. But you like knowing stuff about people. Megan's like, no, that's yeah. No, but it's like you're usually good with people, you usually like people. That's why you're going into the healthcare field. And so you just want to ask them about their, it's, you know, it is all of your business to know about their medications and stuff. Record things, record precipitating factors, record when they had their last you know, incident of, you know, wheezing episode or full-blown asthma attack. So things to avoid, the air powder polisher, that anything that's particulate, aerosols can trigger an asthma attack. So you always want to do a pre-procedural rinse and use a high vac suction. Nitrous is okay for stress reduction. So in an asthmatic patient, nitrous can be used. You know, maybe some people would be cautious or, you know, but it can be used. Is the patient taking systemic antibiotics? So corticosteroids or a systemic steroid that also lowers your immunity, right? It's what gosh, I lost my word about it, but it lowers your immunity. I was going to say something different about it. It's an immune suppressant. That's the word I was looking for. So you want to find out if they're taking an immune suppressant and then talk to them about some of the things that could, you know, occur in the mouth, some things that can happen that are negative about taking an immune suppressant. So oral manifestations from the inhaler, we have hoarseness, sometimes there's a bad taste in the mouth, sometimes a dry, sore throat. It can increase xerostomia. So if they're like regularly taking an inhaler a couple times a day or something, it's more likely that you would see this. There are some relative contraindications when it comes to medications, aspirin or any NSAIDs. So just ask them, have you ever had a problem with it? They might be like, no, I've never had a problem and I take ibuprofen all the time. So then it's fine, but other people might have had a reaction. So aspirin, NSAIDs, barbiturates, narcotics, they're CNS depressants, and you know, anything that kind of depresses the respiratory system is probably not great if you have any kind of a respiratory disease. And then antibiotics, erythromycin, ciprofloxacin, in patients taking theophylline. I'm not going to ask you a question about that, but that is a specific thing. Doctors and pharmacists need to know that as far as I'm concerned. I suppose that could be asked on the national board. So that's why I put it on the PowerPoint, but I'm not going to ask you that on one of my exams. And then there are sulfites and preservatives in local anesthetics, and those can also trigger in some patients a reaction. So just ask them how they've done with local anesthetic. Have they ever had a reaction before? And you could, you could always use a mepivacaine plain. An asthma spacer helps a lot with some of those negative oral manifestations. It gets the medication into a bolus and then the patient like gets it deep down in their lungs as opposed to it like hanging out in the mouth and the upper pharynx. So it like gets it down into the lungs. So a spacer has a really good purpose. And so I think a lot of people who'd be using an inhaler, you know, regularly would probably use a spacer. Okay, so that's all with asthma. COPD is a combination between emphysema and chronic bronchitis. Now, here's the definition again. It's a common is weird to me. I understand that, you know, that definition is like common. Like, I don't know that many people with COPD, but I think that harkens a little bit back to when people smoked a lot of cigarettes, the old school tobacco cigarettes, worked in environments where there's chemical aerosols or mining or dust, chemical dust. So I think more people maybe had COPD, you know, maybe at some point, or maybe some areas of the United States. But the thing that you want to see is it is preventable, generally speaking. COPD oftentimes is associated with something that somebody's been exposed to. So asthma can happen, just you can be born with asthma, but COPD like develops because of exposure. So I want you to just really get those definitions different in your mind. It is treatable, and it's characterized by persistent respiratory symptoms, airflow limitations, due to alveolar abnormalities. So with emphysema, there's sort of this cavitation where all the little air pockets kind of just like degrade and they kind of they die and open up and they don't hold air the same way, or they overinflate and then they can't release the air. So all these kind of abnormalities happen with the alveoli or alveoli. Yeah. And usually caused by significant exposure to noxious particles. So that you could get that mixed up with asthma, but it's not asthma. So try to study asthma and COPD definitions and know the difference so that you can spot those on a test. ASA3, if they have COPD, they are ASA3, and if it's a severe case of COPD, they're carrying oxygen with them, that would be a 4. May find it easier to breathe sitting up, so semi-supine, that's what we call kind of partially back, right? So someone with COPD probably is not going to like going flat back. They're certainly not going to like their feet above their head. So semi-supine, and sometimes even like I've had some older patients with COPD that I could barely put them back. They're like, enough. And I'm like, okay. And I'm like upside down. So but they will find it easier to breathe. It's harder for them to breathe if everything is just pushing on them. So the progression can be slow. They can go into remission, or it could be rapid. It really just depends. I'm sure I told you guys, my dad has mild COPD from smoking, but it kind of goes away in Arizona, but it kind of came out here when he came and stayed with me for 6 months. And then he went back to Arizona. It kind of cleared up again, but now he is getting kind of a bronchial cough again. So it kind of, through the years, it's been pretty stable, but it kind of comes and goes. Okay, causes: cigarettes and air pollution and particulates that they're exposed to in like different, in work environments. But there are other things. There's some genetic predisposition, children that maybe if they were preemies or there was something that happened during birth, they could develop like a COPD as, through the years much more easily. So there are some exceptions, but in general, we think of COPD as exposures that people are exposed to. Treatment can slow, and there's medications and even surgeries. So there are things to be done, especially if it's caught early. So here's some big things to think about specifically for caring for a patient who has COPD. Semi-supine to an upright position, because they're just not going to be able to lay back as easily. Shorter appointments, stress reduction. You can just blanket that with everybody. Talk to them about their meds. If they needed a pre-med or an anti-anxiety, whenever you're working in someone's mouth and they have a breathing issue, that can be anxiety inducing. So you want to be very empathetic and kind of aware of that. Ask them if there's, any issues there. Assess their severity, thoroughly assess their health history. Definitely xerostomia or hyposalivation could be a thing. So talking to them about some treatments or some saliva substitutes, or what do they do to help their saliva flow? Yeah.
For like the anti-anxiety pre-med for like our clinic,
Mhm.
for our purposes, like, do we prescribe, like, do we have the doctor prescribe, like?
Yes. I don't
our
know.
protocol?
That's a great question. I don't know that our dentist is comfortable prescribing anti-anxiety medication. That's a great question. I should find that out for sure. But I would say worst case scenario, if Dr. Schwab or someone is not comfortable with that, then you could talk to them about getting a prescription with their provider. But I also feel like in this environment, nobody's going to really like that. I just, in a private practice, it's actually quite normal. Like I'd have a patient on Halcyon and I'd clean her teeth and her husband would drive her home, and that you see that a lot. But something tells me that in our clinic, people won't be as comfortable with that. So you've just given me a great topic that I'm going to ask, because I don't know, we have certainly had patients that are nervous, but it's almost like they just have to be nervous.
Yeah.
So that's a great question. Smoker, are they still smoking? You're going to consider their perio status, oral cancer, of course. You can always have that opportunity for tobacco cessation. And then some of the really big ones here, sorry, avoid a rubber dam with this population, avoid the powdery substances of like the air powder polisher. Of nitrous is contraindicated. It says avoid, but Isn't it contraindicated? You guys just went through it this summer.
Yeah,
Remind me.
Uncontrolled.
Uncontrolled is
I
contraindicated?
think so.
So maybe that's why it says avoid. And then you can always offer low flow oxygen if you need to. So you can put them on the oxygen part, you just don't want to put them on the. Why did I think it was contraindicated? Do I need to look that up maybe? Is it? I feel like COPD is contraindicated. You don't have to memorize meds for the exam coming up next week, but I put all of these here in a nice little table because I don't want you guys to forget it. Just read through it, remember what some of the names are. Just be like, oh yeah, that's right. That's a med for asthma, or that's a med for COPD. And just keep those names kind of in long acting beta agonist, short acting beta agonist. Did you find it?
Yeah, it says absolute contraindications.
Absolute. So I don't know why I have a void, so I'm gonna have to change that. So it is a contraindication. So and I almost feel like that's a test question, is that it's contraindicated. And that's why I'm like, why do I have a void? But then I'd have a test question that says contraindicated. So I have to update that. So make a big note. Nitrous is contraindicated for COPD. All right, let's fly on to tuberculosis. Tuberculosis is one of those things where you're probably not going to come across it too much, but you certainly could. And it's hard to know. Just the one big sign is if you have a patient that's just hacking and hacking and hacking, and it is a productive cough, you might be like, are you okay? Have you been tested for tuberculosis? Now, they'll probably come in and tell you, I just got over the flu, or I've had this nasty cough. I've been to my doctor. It's a virus that's going around. They're going to have a whole big story. And so usually you're going to be able to get to the bottom of it. But if they come in and they're just like, yeah, I don't know, I haven't had they haven't had traditional like flu symptoms, but they've had this very productive cough, you might recommend that they see someone, and you might want to reschedule. And you can always, you can always talk about, oh, where'd you go? You can always talk about it with the doctor you work for or lead faculty. Be like, I'm a little bit concerned that maybe, we should screen for tuberculosis. Okay, so it is ASA2 if it's inactive and if it's been treated. So if somebody has inactive TB, they've gone through a course of treatment, they have a chest x-ray that kind of confirms that everything is settled in, then they're ASA2. But if they have diagnosed tuberculosis and they're still in, if it's active, then we're not going to see them until they get to that inactive point. And it takes several months, like 6 to 9 months of treatment. So what is it? Who are at risk? We know that people who are immune compromised, and that can be a whole range of individuals. Those living in group housing, so, whatever reason, if that's, different types of group housing, communal living can be harder that way, with different individuals that aren't family, and, you just don't know what the conditions are of the house and things like that, or people come and go. Healthcare workers obviously are more at risk because you're with the general public. Immigrants, if somebody comes from another country that maybe there's tuberculosis in that area and then they have it and they come here. Medically undeserved infants and children are going to be at higher risk, and then medically compromised or malnourished. So all of these people might have a higher risk of having TB. Diagnosis is with a skin test, the TST test, a chest x-ray, and then they can also do a sputum culture, spit up. And treatment is that isoniazid or rifampin, and it takes a long time. You gotta and that's the problem, is people don't like taking medication for like an antibiotic for like 9 months. And so sometimes when they start feeling better, people stop taking the med, and that's, can contribute to antibiotic resistant. So signs, disease transmission is the greatest concern. Remember from pharmacology, the good news is that you have to kind of be in close contact for a long time in order to contract TB. So like if you're wearing a mask and you're just cleaning somebody's teeth for an hour and they didn't really cough, you probably are totally fine. But in general, you don't want to expose yourself unnecessarily. Usually you have to like be with someone in a room, for a long time with lots of coughing going on. So recognizing signs and symptoms, if positive, you want to record the test results, the date, you want to track a chest x-ray, make sure that they get a follow-up with the doctor and that everything is, been treated and they're good and everyone can move on from that. Cough etiquette is important, washing hands, coughing in your elbow or in a tissue and then washing hands. Is important. So, okay, so that's all for TB. So pneumonia, very common. Lots of people get pneumonia. Usually, there's a couple different categories of pneumonia that you have to just be aware of for this class or for this exam. So pneumonia is inflammation of the gas exchanging units in the lungs. And the trick here is it's caused by microorganisms, bacteria, fungus, viruses. So that should be your tip off that we're talking about. We're not talking about asthma or COPD. We're talking about pneumonia. As you can see, it can also be irritating. Chemicals can also lead to pneumonia, but a lot of times it's from some kind of a microorganism. So there's two types. There's community acquired, and then there's nosocomial. And so those are two different types. And the first one we'll talk about is the community acquired. It's kind of just everybody has these bugs living in their throats and we pass it around in the community. That's basically that's community acquired pneumonia. It's kind of like whatever the bug is that's going around. The nosocomial is a little bit more nuanced. It's hospital acquired, ventilator associated, healthcare associated pneumonia. And so these are all pneumonias that usually people pick up when they go to the hospital because the hospital has the most germs of any place on the planet. So they always say don't, if you can avoid it, don't go to the hospital because it's just, all sick people go there. And then they also use so much cleansers and things that sometimes they get, resistant to these things. And so, or maybe they're not so good at wiping something down. I mean, maybe, I don't know. We could go on about that. I don't want to think about it too much. But so very different spectrum of organisms. They're not the organisms that are just sort of swirling out in the community. They're more specific to the hospital environment, not normally found in the oropharynx. Commonly are multi-drug resistant, can rapidly develop resistance. Frequently prolonged hospital stays, increase healthcare costs, very often a cause of death for the elderly. That's why it's kind of sad. I don't know if I said this in farm, but it's like elderly people go into the hospital to because they broke their hip and they end up dying from pneumonia. That my grandma died of pneumonia in the hospital. It's very common because they're older and weak. They're there for something else, but if they stay, for a prolonged period of time and they acquire pneumonia, and that can be what ends up, being the thing that kills them. Okay, aspiration pneumonia is another kind of another kind of pneumonia, most often associated with the elderly because they have that word dysphagia, difficulty swallowing. And so they might not be able to handle they're eating or drinking and they start kind of choking and they aspirate some of the bacteria that's in their mouth. And if they don't have good oral hygiene, which oftentimes elderly people don't, if they're in an assisted living, or you guys are starting to see that, right? You go on the rotations to the assisted living. Sometimes the oral hygiene is horrible. So if that bacteria gets aspirated, it can cause pneumonia. Ventilator associated, I start because I probably asked you a question about it. A patient free of pneumonia on hospital admission. So they go to the hospital, they don't have pneumonia, they've been intubated or mechanically ventilated for at least 48 hours and they start to develop pneumonia. And that is, biofilm is thought to develop on the endotracheal tube and migrate down. And so there's some things that they should do, hopefully, keep the mouth very, very clean, swab the mouth with chlorhexidine. There's, hopefully they'll do things to keep that clean to prevent that from happening. But it is difficult to perform oral hygiene if somebody's intubated. So usually it comes down to swabbing. They have these little sponges that you maybe use chlorhexidine or something like that. And of course they're not going to be able to have regular oral hygiene care if they're intubated. So This is some kind of neat in like I just clipped this picture. There's a whole little booklet, an educational booklet of different products that can be used. If any of you just get a burning desire to do mobile dental hygiene, or you really want to work with people in assisted living or group homes or adult foster care, special needs, and if that's just your thing and you like either get in with a company or you build your own company and do that, these patients that are intubated or have high special needs, very few people are specialized and trained to know how to help them. And so you can really have a niche, kind of specialty. And there's different things, there's different products that you can use. There's, mobile suction things that you can go in there with, like something that, a toothbrush that would spray water and you also suction at the same time so that nothing is, go just like what you guys do in clinic. But I mean, it's mobile. And so just so nothing would go down past the tracheal tube. But there's usually it's like gels or very, very little water to no water at all. And you just swab like an antibacterial gel or solution. So proper oral care for elderly, the infirm or intubated patients is critical to prevent the pneumonia. So good oral hygiene, talking to nurses, CNAs, caregivers, to educate them about this. They might have no idea at all about what is the best way to move forward with patients that need this kind of care. So this is just saying some things: cleaning dentures, brushing, flossing. For a ventilated patient, pooling of secretions should be minimized, regular suctioning and draining. Anyone who has any of these mechanical, or if they're intubated, they really need constant care. And so the people who are caring for them should have this education. So important, proper OHI is super important. Okay, I think I'm gonna be able to get through it. So excited. So I always want to do like case studies, and I always have it in my head, like I'm gonna do a case study with them, but I knew today was there's no way. And so hopefully the next units coming up, we can do some more like cases and talk about stuff in groups, and it won't be just me yakking at you guys. Okay, so this one has a lot of information because we don't really do very much with this, but you guys can pull this into clinic on your own just because you're interested in it. So I have a pretty good amount of slides here for snoring, sleep apnea, and then you can talk to your patient about it if you notice stuff when you're doing the EOIO. And then there's all kinds of classes. There's gobs and gobs of classes after you get out of school on sleep medicine. Sleep-related breathing disorders, obstructive sleep apnea. So it's kind of a spectrum between snoring and obstructive sleep apnea. Somebody could snore, but if they actually literally stop breathing, they have an apnea episode, then they've kind of crossed the Rubicon. So usually when they're being tested, they go to a sleep place and they record them and see how many times they have these apnea events where they stop breathing. And then they kind of categorize them on the spectrum. So obstructive sleep apnea, a condition that involves either partial or complete collapse of the upper airway. A lot of times it's like the mandible falls back and the tongue blocks. People's tonsils can be really large. They used to kind of say, people who have like thick necks or overweight, or there's all these specific things. But I mean, I've had patients that are just thin as thin can be, and they have sleep apnea. So it can be the size and shape and just the way you sleep, and it can be all kinds of different things, really. But classically, there you do seem to see a little bit more with larger men that are overweight, or even women. A condition so I already said that, characterized by loud snoring, periods of breathing cessation, and then a waking from that they stop breathing, and then it's kind of like this gasping or choking. It causes a decrease in arterial oxygen, and so in general, it's very hard on your body for your body to drop down and lose oxygenated blood, and then you'll come back up and then you drop back down. And it's just chronically, it's very hard on the body. It's like high blood pressure. It's just one of those things that over time, it's just not good for you. So you can have mild, moderate, severe. It just depends on how often you stop breathing. And it has been associated with metabolic disorders, so things like diabetes or different metabolic disorders, cardiovascular disorders, and other respiratory disorders as well. So there's a lot of repetition in these slides. So go through and read the slides, but I'm just going to summarize as I go through some oral manifestations. You're going to notice like on the small airway, right? You look back there and it's like, oh, their uvulus touching their tongue, or, say on, oh, their uvulus still touching their tongue or the back of their throat. I can see their tonsils, they're enormous, they're practically touching, or, just different things like that. If there's like redness, but they're not complaining of like a sore throat. Sometimes people have very narrow, high vaulted palates and everything's kind of collapsed in, a very large tongue. Like there's just different things. If you notice scalloping, the scalloping on the sides of the tongue, if they grind their teeth, sometimes that's associated too. There's so many things that can kind of overlap, and different people can have different things that you'd notice in their mouth. Erosion, acid erosion. There's been studies that connect bruxism with GERD, or what does GERD stand for? Like, to think of all the words, and my brain wasn't going to do it, so you did it for me. So yeah, patients have GERD or acid reflux. There's been some studies that seem to correlate those two somehow. So you might see acid erosion on the backs of the teeth, constricted maxillary mandibular arches. If there's not really any room for the tongue to go, it's, if they don't have a large enough palate, the tongue falls back to the back of the mouth. They have a smaller mandible, class 2 occlusion. Again, they just have it's architecture, it's anatomy. Things aren't, they're at a higher risk for it because of their anatomy. Nasal congestion, smoking, excessive alcohol use. If somebody drinks heavily before bed, guaranteed they're going to have some apnea while they're sleeping. Large tonsils, large adenoids, the jaw size. So what you can notice, if it's your spouse or something, you can notice the loud snoring, the choking or gasping, the stopping of breathing. It can affect quality of life because obviously our sleep is everything. So usually people who've been struggling with this for a long time, they'll have mood swings. It can have psychological effects, anxiety and depression. It can have health effects, cardiovascular, long term. If we don't get good deep sleep, oxygenated blood, it's going to affect these areas. People could get sleepy during the day. They can, if somebody falls asleep in your chair, they might just be really relaxed and like you. I had that happen all the time, but it could also be that they're sleep deprived. So if they're falling asleep in your chair, be like, are you just really comfortable with me, or is there something else? Or you can add up the things. Like if you see some of those physical signs and you can't arouse them while you're cleaning their teeth. You guys will absolutely experience this, I promise you. Then you could always think about I wonder if there's something going on. I wonder if their sleep is disturbed at night. So treatment, people can have CPAP, the continuous positive airway pressure. They can have BiPAP, which is a bi-level positive airway pressure. People can have just little cannulas. They can have a full mask. It's really important that you talk to them about humidifying their room. They can dry out tremendously from a CPAP machine. They also need to keep it very clean. They need to follow the instructions to keep it clean so bacteria and mold and whatever doesn't build up in it. So you can, as far as your comfort level goes, you can talk to them about those things. There's obviously some people that are not going to be able to tolerate those CPAP machines. And so there are some mouth appliances. The only ones that I've ever had any experience with are the MADs, the mandibular advancement devices, that what I've highlighted there. I've never ever seen one of these that holds the tongue forward. Somebody might make some, they say it's a treatment. I've never seen that as a clinician. But I have had patients that have the MADs. I have had patients talk about the TMJ discomfort. Their bite is off. They can have permanent change in their bite. They'll give you a bite tab to a bite block, or it's like a little one doctor I worked for called it a jig, but you bite on it and it's your natural bite and it relaxes as the muscles relax, it goes back to your normal bite because all night long you're like this, like pulling the jaw forward. And so when you wake up in the morning, your bite is off. And so then as it takes, a few minutes of wearing this little splint and it puts you back in your normal bite. But I've gone to classes before where they say over time you have some permanent change in the structure of like your TMJ. Um, but clinical applications, the main thing, you guys can't diagnose um, OSA, but you certainly can look for signs. You're in there already doing an EOIO. So my speech in the last 5 minutes is just make sure that while you're doing your EOIO and you're looking at their airway and you're looking at their tissue and you're looking at their anatomy, take that and combine it with something else that you see. Take that in combination with their overall health, their overall size, the way that they, talk to you during the appointment. If they talk, if they're yawning a lot, if they're, whatever, you talk to them, you can ask them about their sleep and if you sleep well, you get enough sleep. And you just want to kind of think holistically about all your patients. And this is just a good example of how you can pull something in that you already do to possibly refer somebody to see a sleep medicine dentist. Some dentists specialize in it or just their physician. So you can do your regular EOIO. You can question them about their sleep habits. They obviously probably, you need to refer them. We can't do any treatment here. But if you can tell that it's probably something to think about based on their anatomy and maybe some conversations you've had, you definitely want to see if you can refer them to their primary care. If they say they have a CPAP or a BiPAP, you want to talk to them about the cleansing it and the using a humidifier in their room. And then check for xerostomia, because that's probably a big thing for them. So you'd want to educate them on using a saliva substitute, keeping their tissues hydrated with, water throughout the day and at night, maybe if they wake up. But that would be, I don't know, they probably don't want to deal with water at night. So a humidifier is probably the best bet for that patient population. And so these are just some things that you can think about to kind of put it all together in a slide. If they complain about being tired or irritable, or you pull that out during your appointment. If they have these anatomy enlarged tonsils, microglossia, dry mouth, attrition, mouth breathing, hypertension, obesity, sex and age. So if it's a male, older males tend to be in the category that will have more OSA. But again, I've seen it any age, any person, any size. Arch form and size, Mallampati score. I'll show you that in just a second. Dark circles under their eyes. Do they fall asleep in your chair? So you're just putting all the pieces of the puzzle together. This is the Mallampati score. And basically you just look at when you tell your patient to say, if everything opens up, okay, great. But if it's, now if you're a little bit closer, like that uvula is getting closer to the tongue and you really say, but there's limited space. And then as it gets more and more closed, Lola, my daughter has, I think she's probably I think she might even be like a class 3. And I'll be like, no, go like really because I want to see if she can open up because she's got huge tonsils, little airway. I think I get worried. But so she's like somewhere between at least a 2 and a 3. But so you can do that with your patients that you have in your chair now. If you're really into this and you really want to bring some extra stuff into your practice, there are a couple really good questionnaires and you can just memorize it too. Like you don't have to go through the whole little thing, but you can like memorize some of these questions and ask your patient, or even have this in like a laminated that you just pull out and you kind of go through a checklist if you're really concerned that somebody might kind of be in this category. There's the Stop Bang questionnaire, and then there's the Epworth sleepiness scale. So those are two good, easy little things that you can run through with a patient if you feel that they have a lot of risk factors for OSA. But just the big take home is remember that you guys already do an EOIO, and so you can incorporate some of these things without having to feel like you're doing too much extra. It's just another thing to think about. Another thing to think about. Do you guys have any questions about anything, the exam, the content that we talked about today? I ended with 4 minutes to spare.
Way to go.
I know. No, we're not gonna lecture after the exam next week. We'll start at 9. And then you guys are free to go after that. So that's that. Okay, yes, Kayla. I don't have a study guide. But the PowerPoints have a lot of things that are kind of highlighted. And then it is blocked as like 10 questions for each topic. So it's pretty evenly dispersed. Except for, like I said, the sleep or the substance misuse, those ones are a little bit less. Yeah. Mhm.
Yeah.